So, okay, so where were we? Let's see where we were. I'm going to tell Greg that I like you more than all of the other classes, because I totally do.
Do you?
Yeah, I do. You're funnier. And you think I'm funnier, which is a really important part of the equation. So that's really important. Okay, so let's see. I forgot where we were. Where were we? We did that right here, right? 3? Okay.
Yes.
Alrighty. Okay, so here we go. Here's what we're going to do. We have to get the whole roots and Ramus thing together. We started it last time, but we're going to practice it, and we're going to practice like moving through it. So remember that when we were talking about roots, what we were saying is that if we get information to go through the spinal cord, this dorsal or posterior root has what functionality? Sensory, right? And then if you go through the gray matter, what's this called? Right back here. The gray matter back here. Posterior horn, right? And that's sensory, right? And then what's this one? Anterior horn, which is motor, okay? Then I'm going to go back out. What's this called right here? Anterior or ventral root, right? And then once they come together, they are no longer exclusively sensory or motor, because they can't be, right? Because you put both of the fibers together in the same wrapping. So then they're mixed in function, right? And this part is called a what? Spinal nerve. Okay, so let's put that together with this real quick, and then we'll come back and add the Ramus. What I mean is the spinal nerves that you are seeing come out here, yes? They exit through the intervertebral foramen, and they are all mixed, right? All, when you, cranial nerves, right? Some say merry money, but my brother says big brains matter most, right? They are all bees. So it'd be a super boring song, right? So make up a song with 31 bees. You don't need to, because it's 31 bees. They are all mixed in function. Does that make sense? They're all both sensory and motor. Everybody okay? Okay. So these are all both sensory and motor. Okay. So we're going to come back to those in just a second. Let's do the roots and Ramus real quick. Okay. So what we are going to see with the roots and Ramus, we already did that, but we'll talk about it just a little bit in a second. So let's do this part right here. So each spinal nerve almost immediately branches into a posterior ramus and an anterior ramus. Common student mistake, you cannot use roots and Ramus interchangeably. They're not the same thing, okay? So what we are going to say is, and we talked about this at the end last time, here is the posterior or dorsal ramus, and here's the anterior ramus. This one is related to autonomic function. We'll talk about it separately, okay? So posterior ramus. Who remembers what I said about functionality of the posterior ramus? Go ahead. It's not sensory. The posterior root is sensory. What does the posterior ramus do? Go ahead. Everything behind the spinal cord. So the Ramus, guys, are not about separate functionality. They're about location. Yeah? So the posterior ramus innervates everything posterior to the spinal cord. Why is it so tiny? There's not a whole hell of a lot going on back there, right? There's a little bit of musculature, comparatively speaking, right? How much sensory function do you have here compared to here? Not a whole hell of a lot, right? You can't really tell what's going on. So collectively, all of the fibers that are coming from and going to that region are far fewer fibers, right? Does that make sense? So this is the posterior ramus, yes? Okay, and then this big honker right here is the anterior ramus. Now let's try again. What is the anterior ramus innervate? Everything anterior to the spinal cord, both sensory and motor function, yeah? And so it's got a lot of work to do, yes? It's comparatively much, much larger. Does that make sense to you guys? Okay, so let's look at the spinal nerves real quick, and then we're going to come back and we're going to practice a loop through this, okay? All right, so let's talk about this real quick. Okay, so if we look at the spinal nerves, remember how they're named and numbered, right? We've got C1 through C8. They're usually numbered for the vertebra above them, but with the C's, with the cervical ones, we have one extra because there's one that starts above the first cervical vertebra. So we ended up with 8, okay? But they're not just called C1 through C8. I also want you to know their real name, which is cervical spinal nerve number 1, right? through 8. That makes sense? These are thoracic spinal nerves, abbreviated T1 through T12. These are lumbar spinal nerves, abbreviated L1 through L5. Sacral spinal nerves, S1 through S5. And then there is one coccygeal spinal nerve. Everybody okay with that? C01, yeah. Not as in 0, yeah? That makes sense? Okay, so that is their names. But what you are actually seeing here is really not the entire spinal nerve. What you're seeing is, in order to get this picture, didn't they have to cut off the posterior ramus? Yeah? So you are not actually memorizing any of the functionality of the posterior rami of the spinal nerves, because most of the function of the spinal nerves comes from the anterior ramus, right? That makes sense? So all the stuff that you're memorizing in your lab book actually comes from the anterior ramus, right? Because you're innervating arms and legs and all of that kind of stuff. Does that make sense? Okay, so you cut off the posterior ramus here. But before we get into the specifics about that, I want to practice just a little bit with this guy right here. And what we're going to do is I'm going to give you a situation, and then you guys are going to get me through the right roots, the right rami, the right nerves, the right part of the spinal cord, right? In order to have a sensory and motor response. So here's what I'm going to do first. I'm going to say, okay, I have an itch on my back, yeah? And I'm going to reach my arm around and scratch it. You with me? Okay? So itch on my back. So the first relevant structure in this picture that would be involved in the itch on my back is what? You can raise your hand if you think you know it. The what? Posterior ramus. Yes, right? Taking that sensory information from my back. And then from the posterior ramus, you go to this structure. What's that? That's the spinal nerve. Yes? That makes sense? And now how do I get into the spinal cord? Help me. The dorsal root and the dorsal root ganglion. Yeah? Okay. And then which part of the spinal cord first? Posterior horn. Yes. Then anterior horn. Now get me back out. Anterior or ventral root, which is what functionality? Motor. Now where? Spinal nerve. Now get me here. Anterior ramus, yeah? That makes sense? Okay. Got it? Could you do it if it was hand on a hot stove? Only real difference would be what? You start at the anterior ramus and end up at the anterior ramus. Does that make sense? Right? Okay. So roots and rami are different, right? They have different functionality, and a good student would be able to track all the way through, right? You guys are all right with that? Okay, so you can't use them interchangeably. These are related to the sympathetic nervous system. We can talk about those later. Okay, so now, next thing to do is we're going to concentrate on the anterior rami and the branches off of it, which are going to form your major nerve plexuses. And I know you want it to be plexi, but it's not. It's also not octopi, it's octopuses, FYI. Everybody thinks you're wrong, but you're just so right they don't even recognize you, okay? You're like, I am so right that we are not even in the same league. So what is a plexus? What a plexus is a big collection, sort of a tangled network of nerves that comes off. And really specifically, guys, the plexuses are formed from the anterior rami, not the posterior rami. Posterior rami are simple enough that they don't really knot up very much, okay? And the plexuses are actually relatively easy because you've got this cervical plexus. And with the cervical plexus, if you see the atlas and the axis, that's probably a cervical plexus, right? And then you've got this brachial plexus that's named not for where it comes from, but for where it's going, right? And with that one, you're generally going to see it go all the way, and you're going to see the first rib with that one, if you're looking at it. We'll look at these in just a second. With the lumbar plexus, how do you know lumbar? Well, you don't see the atlas and the axis. You don't see any ribs, and you also don't see a sacrum. That's how you can tell that one. And the lumbar plexus, part of the reason you can tell it from the sacral plexus is it dives anterior to the os coxae. Does that make sense? And then once you get it down into the sacral plexus, well, it's coming out of the sacrum. So it's the sacral plexus, right? And it also dives posterior to the os coxae, right? So what we're going to do is the same thing you guys are doing in lab, and you can get out your lab book if you want to. So you are responsible in lecture for the same nerves, the same innervation patterns, the same muscles, and the same sensory innervation, because I wrote that too. Okay? So I know exactly what I want you guys to learn in lecture and lab. Now, I'll teach you how you can be tested on them in lecture because it's going to be different than in lab. All right, so here we go. We are going to look at the first plexus. So this is from an anterior view, and specifically these are the anterior rami. Now you do not have to know all of the individual structures that are involved here. The blue ones are actually not part of the plexus, like some of the cranial nerves run down there, right? Now, what you don't have to do for me is to label these nerves, because even if I had to do that, would they actually look like that in a cadaver? No. Hell no, it'd just be a rote memorization experiment. It would be pointless, right? What you do have to generally know is what the cervical plexus does. Cervical plexus does mostly what you would expect it to do. It innervates some anterior neck muscles. You didn't learn them all. There's a whole bunch of muscles under the platysma that you didn't learn. They're called the neck strap muscles. And it also innervates sensory function of like the neck and a little bit of the shoulders, which makes sense, right? Okay. So for each of these, you have to know sensory and motor function. Here's the general rule. If you can figure out what muscle it innervates, it usually innervates the skin close to that muscle. So you can kind of guess. Now there are exceptions. There are weird ones, right? Like the musculocutaneous does something weird down there. But most of the time, you can get a good general guess, right? Okay. And then the exceptions are easier to memorize if you know the general rule, right? You're like, that one does something I didn't expect it to do. All of the other ones do what I expect them to do. Okay, so the cervical plexus comes out from C1 through a little bit, sometimes through C5. Not C5 is also part of the next plexus. Now, why is there overlap? Why didn't they get it together? The overlap is really actually very important because then you have redundant innervation. So if you damage something, you might not lose complete innervation to the structure. Does that make sense? Okay, so why, for instance, this phrenic nerve, which is the only nerve that you need to know by name out of the cervical plexus. And the phrenic nerve does the exception to what the cervical plexus does. Cervical plexus is mostly neck stuff, sensory and motor, a little bit of shoulders. The phrenic nerve dives down and goes to the diaphragm. Yeah? So the diaphragm is pretty damn important, isn't it? What does it do? Breathing, exactly. So the diaphragm is responsible for most of your breathing. The intercostal muscles help, but they're not primarily responsible for it. Now I want you to look at innervation of the diaphragm. So let's just see this redundancy that we have. So if you're trying to innervate the diaphragm, notice that a few of the fibers can come through C5, right? Most of them would come through C4, but then some of them come through C3, right? And that's good, because if you damaged one, you have that redundancy, right? You might have weakness instead of paralysis of the diaphragm. Is that okay? Okay, so what they say when they are describing so if I had a spinal cord injury, right, and it was really high, how high does it have to be for me to die because I've lost innervation of my diaphragm? Above C3, generally speaking. And every once in a while, somebody has a few fibers coming through C2, but not very often. So they say C3, 4, 5 keeps you alive, right? I don't remember where Christopher Reeve was damaged. It seems like it was between C4 and C5, or maybe C3 and C4. And he had partial innervation of his diaphragm. He was on a ventilator part of the day and then not part of the day. Got really exhausted. But by the way, if you have this high spinal cord injury, not only do you lose at least partial innervation of the diaphragm, you also lose intercostal innervation. Because intercostal comes out from the thoracic region. So you're going to have a lot of trouble breathing. Does that make sense? So with the cervical, you should be able to recognize a picture as the cervical plexus. Do you need to be able to label any nerve out of it? No. I could make you do the phrenic nerve, but it's not going to look like this, right? The way I find the phrenic nerve in the cadaver is find the cadaver, find the diaphragm, and follow it back up, right? You're like, oh, that's definitely the phrenic nerve, right? That makes sense? So it's, and there are paired phrenic nerves that go to the two halves of the diaphragm, and they're pretty easy to find. You kind of have to like pull the heart aside and follow them down. Does that make sense to you guys? Okay, so that is the cervical plexus. You should be able to recognize it by the atlas and the axis. Let's go down to the next plexus. This is the harder one. Okay, so this is the brachial plexus. And the brachial plexus is named for where it's primarily going, not exclusively, but primarily going. And notice that it's primarily coming just below C5. There's a little overlap between the cervical and the brachial plexuses. C5 through T1. So how do you tell if you're in the brachial plexus where you're going to see the first rib, right? That makes sense? Okay, so please note that you could get confusing as hell with this one if you wanted to. And Mark Nielsen, who teaches anatomy up at the U, makes everybody not just know the nerves, which is the yellow part that you guys have to know. You have to know the trunks, the cords, the branches, all of them, right? So you have to know all of this. But let's just big picture it right now. These are all anterior rami, yeah? The posterior rami are doing something else. And so you can follow the anterior rami out, and eventually you'll get to the nerves. And these are the nerves down here. You are not responsible for these individual names back here, only nerves, okay? It's hard. This stuff is really hard. Okay, so now once you get down to the yellow, you sure as hell are responsible for the yellow. And the yellow is the actual nerves. So the brachial plexus is the one that's hardest for most people. And the reason it's hard is because you have to know a lot of the nerves in the brachial plexus. But it's actually pretty easy after you do process of elimination. Okay, so did you guys get to see the brachial plexus in the lab? Okay, so when you're doing brachial plexus, first do the easy ones, right? So the brachial plexus, find the one that's running back here, and that is the what? Long thoracic nerve, right? That one's easy, right? Then knock out another two that are easy. And they go this way and innervate the pectoralis major and the pectoralis minor. And what are those? Median and lateral pectoral nerves. Which muscle, major or minor, gets innervation from both? Medial. Which muscle?
Major.
Pectoralis major. It's a big honker, right? It gets innervation from both. Yes, does that make sense? Okay, so that's pretty easy, right? Those are a little hard only because they're really easy to break. So be careful with nerves on the cadaver. Don't yank back the pectoralis major, because then you'll pop the nerves and you'll still be tested over the damn thing. It'll just be harder to get the right answer, right? So be gentle with them. So now we have three already taken care of, right? We've got the long thoracic, we've got the medial and lateral pectoral nerves, right? And then we start doing the harder ones. And the harder ones are not that hard, guys. It ain't too bad as long as you have somebody, and look at it on more than one cadaver so that you really get confident. Because it doesn't look at all like this. Sorry, there's a bunch of crap in the way, right? So it doesn't look like that. So what it does is look more like this, which immediately makes you think, I am literally going to drop this class. Oh crap, it's too late. Can't drop it. Okay, so the next thing you do is you do process of elimination and get one of the easy ones out. And that easy one that you get out of the way really quickly is this guy, which is the axillary nerve. And the axillary nerve is easy to find because it doesn't flop around, it doesn't go down, it dives immediately into the axillary region, and you can't really move it very much. So it's really tight in there. Does that make sense? Okay. And then you only have 4 left, right? So we did long thoracic, right? Medial and lateral pectoral. And then we did axillary, right? And generally what they do is kind of what you'd expect them to do. They innervate the region that it looks like they would innervate, right? They're going to places that you'd expect them to. So you are responsible for, with those, the muscles that you learned already. And FYI, if this thing seems hard, what I did 2 years ago is that innervation column used to be part of the muscle lab. So in the muscle lab, you needed to know the muscle's name, its attachment points, its action, and its innervation. All of that. So what I did is I took the innervation out and I put it over here, right? So you can do the innervation later. And collectively, after the semester's over, you know it all, right? In theory. I don't know how much of it you retained, but you knew it all at one point, okay? So now what we have to do is we have to do the last 4, right? And the last 4 are, you've seen them before. I will show them to you a couple of different ways. Did anybody show you the M? That's how I do it. It's not the only way to do it. And some people are like, I don't see what the hell you're talking about with an M. Well, sorry, I tried to show you my M. So I'm going to show you the M. You ready? Okay. What we are going to do is this M. Do you see that right there? And then the other one that's not the M is the only one left. Okay, ready? So what we're going to do, we're going to kind of draw it like that. Okay. And you guys are going to tell me a little bit of functionality, even if you have to get out your lab book, right? So this one that is lateral most on the M right here is the musculocutaneous, which is really telling you that it's both, right? It's muscle and skin nerve. Somebody tell me a muscle that it innervates and the sensory region that it innervates. Biceps brachii, okay. What? And the sensory region that it innervates? So this one's the exception to the rule. Remember how I told you that generally speaking, if you do muscle here, you're going to do sensory of the same region? So note to self, the musculocutaneous is weird because the motor innervation is here, but the sensory innervation is here. So almost everything else works exactly as you would expect it. Okay? So for me, it's easy if I note the exceptions, right? Okay? All right. So that's the musculocutaneous, right? And now what about this long one that's going down the middle? Okay. That's the median nerve. Okay? The median nerve, by the way, if you want to remember what it does, it actually is the one that gets compressed with carpal tunnel syndrome. Now tell me some muscles that it innervates. Doesn't that sound like where it should go? Yes? Choose a flexor. Any flexor. Guess it if you have to, right? So on this side, right? And what about sensory innervation? What kind of sensory innervation is it responsible for? Yeah, it's like this here, right? Right? So the tips of the lateral three fingers is here, right? Did you get median? So the palmar surface of the hand. Isn't that pretty consistent? So with the median nerves, choose a flexor, right? Memorize it if you can, but at least get a flexor in there, right? And then the palmar surface of the hand. That makes more sense than having a flexor and the dorsal surface of the hand, doesn't it? Okay? That is carpal tunnel syndrome. That's the one that gets compressed with carpal tunnel syndrome. Is that okay? All right. So then the last one on your M is over here. Yeah, that's the ulnar nerve. Okay? Somebody tell me a muscle that the ulnar nerve. It does a flexor. What else does it do? Did you learn any more of it? Or you can feel faster? It does some more flexors and most of the hand muscles, right? So it does some more flexors and most of the hand muscles. Okay? And then how about sensory function on that one? So ring finger and pinky. So it's going to this side, right? That's where I would expect the ulnar to go, right? So did we say ulnar? Yeah? Okay. So let's see. Where's your ulnar one? Okay. So notice that the ulnar innervates the flexor carpi ulnaris. Isn't that a good one to memorize? Ulnar, right? That makes sense? Innervates the flexor carpi ulnaris. That makes sense? Okay. So basically there's some logic to it. I don't know how they're going to test you. Are they going to ask you every single one that it innervates, or are they going to be nice and ask you one that it innervates? If they ask you one, huh?
She already said one.
Well, it depends on who you have, right? What did Jeff say? What? Ramo. What did Jeff say? Who's going to ask you? All of them? Or one? Jeff.
Knowing Jeff.
Knowing Jeff. He's like, can't you learn them all? You know what he does? Did he tell you what he does to make his tests?
Yeah.
He just sticks it into a computer program, randomizes the terms, and then asks those. So probably you'll have to know all of them. I don't know. Okay. So he's like, that's a decent way to do it. Okay, we've only got one left. And that's this little bugger right here that is hard because it innervates so damn many things, right? Radial nerve. So how do you find the radial nerve? Well, you found your M, right? The radial nerve dives deep behind it. Okay, that's the radial. It's not part of the end. It dives deep behind it. And if you follow it for long enough, it goes out that side and down the radial side. Okay, does that make sense? Okay, so let's look at it in an arm, even though we know it doesn't look this pretty in the cadaver. Let's follow the radial nerve. So first, let's find our M, musculocutaneous, median, yes, and ulnar. And then follow the one that goes behind it, dives behind the humerus, and comes out that side. That's the radial nerve. Now, if you have a good cadaver, be gentle. Find the radial nerve and pull on it. You should see it running along the lateral surface of the arm. Right? That's what it should do. Now, who's filled out their tables and knows some muscles of the radial nerve?
The long head of the triceps brachial.
Long head of the triceps brachial. Yeah, go ahead.
Supinator.
Supinator, good. Yeah, supinator, good. What else? There are a bunch of them, huh? The Antonius, right? So it's going back here and coming out this side, right? And what about functionality sensory? What does it do sensory?
Most of the dorsal surface.
Most of the dorsal surface, right? We already took care of most of the ventral surface, most of the dorsal surface right here. Does that make sense? Okay, so do you see that, yes, there is some memorization, but there's also some logic that you can use with these. It's not rote memorization, right? Okay, so let's see if you guys can do it. Try not to look at the labels. Ready? Okay, so do it with me. What is this nerve? Ulnar nerve. What is this one? Median nerve. What is this one? Musculocutaneous. What is this little booger that goes in and dives right there? Axillary. And what is this honker that goes and dives out here? Radial. See, it's easy, right? And there are 3 that aren't in there just because they didn't put them in there, the long thoracic and the 2 pectoral, right? And that's the only really hard plexus that you learn. And it's really not that hard after you've practiced with it a little bit, right? Okay, so let's do the thoracic spinal nerves. Now, the thoracic spinal nerves do not form a plexus. They don't get all wound up with each other. They just stay relatively parallel to one another and primarily form the intercostal nerves, which I'll bet you can guess which muscle they innervate.
No.
Can you? No, you can't. You can. I believe in you. Intercostal muscles, both external and internal intercostal muscles. And what they do as far as sensory innervation is really primarily the lateral and anterior sensory innervation and a little bit of the pleural cavity on the inside. That's what you'd expect them to do, right? That's what they do. Okay, everybody good with that? Okay, now, last 2 plexuses is this one. I tell that I am a lumbar plexus because I can't see any of my other landmarks. Obviously not a sacrum, yes? No atlas and axis, no ribs. Right? Okay, so this is going to be the lumbar plexus. And the lumbar plexus is going to, as I mentioned, let's look at it here first. It is going to dive anterior to the os coxae, right? Okay, and it's pretty damn easy because you only have to know 2 nerves out of it. And they're both super duper easy. So it dives anterior, and then you've got 2 nerves that you have to know. One of them is the femoral nerve, which stays relatively lateral and runs on the anterior surface, and probably innervates some crap that you'd expect it to innervate. What does the femoral nerve innervate? What? What does it innervate? You got it? Your quads. That's what you expect it to innervate, right? Yes, the rectus. Yes, rectus femoris. That's like a super safe one. Please note that the yeah, all of these little guys right here, it innervates, right? So it's primarily doing the anterior thigh, primarily, okay? And note that it like branches like freaking crazy, but we don't make you know the branches. So if you find one that is on the anterior thigh, you get to write femoral nerve, right? And you only know one other nerve out of there, and it's super easy because that one actually starts out from the lumbar plexus, and instead of going anterior and a little bit lateral, it goes medial, right? Because it's eventually going to dive through the obturator foramen, right? That's called the obturator nerve, right? So the obturator nerve you can see in a cadaver right here, right? So if you found the femoral nerve, which is right here, you can follow it under the structure right here, and it goes onto, you can pull on it and see where it comes out. And then the obturator nerve is the only other one that you can see, and it's more medial, right? What does the obturator nerve innervate? Some muscles.
The abductor magnus.
Yeah, the adductors. Isn't that what you would think it would innervate? Because it's going there, right? And what about sensory innervation? It's medial thigh, right? Right? So you're feeling this. Somebody touches your medial thigh. Maybe it's welcome, maybe it's not. Maybe you're about to punch them, right? Regardless, it goes through your obturator nerve, and you can say, you are irritating my obturator nerve. Hands to yourself. You're irritating my obturator nerve. Or that's a little too close to my obturator nerve, right? Like get it back down toward the knee. What? That's exactly what you wanted in this situation anyway, right? There was no consent for obturator nerve stimulation. It's all right. You have to find somebody eventually that just embraces your particular brand of nerd, right? That's what you got to find in your life. My husband just rolls his eyes. Okay, so that's femoral and obturator nerve. And then our last plexus is the sacral plexus. And if it's coming from the sacrum, that's a good indicator that it's the sacral plexus. So here's your sacral plexus. Now, if you can see where it's coming out, we've got both anterior and posterior dissections of this. But either way, if it's coming from the sacrum, it's going to be the sacral plexus. So here's an anterior dissection. But of course, more likely you are going to see the nerves of the sacral plexus from a posterior aspect simply because that's where they go, right? So when you're looking for nerves from the sacral plexus, you're usually looking at a prone dissection instead of a supine dissection, right? That makes sense? Okay, we have one cadaver on this campus that has the sacrum actually pulled off so you can see where they're coming from off the spinal cord. Like the sacrum is so hard to actually get loose. It was a really long dissection to get done, but the TAs did it. They were like hacking, it was like involved chisels and bone saws. It was awesome. Okay, so as far as the sacral plexus goes, it's pretty easy. I think all of this is easy. I guess you guys can tell. It's not very hard. The biggest nerve in the body is the sciatic nerve, right? And it runs this way, yeah? And if you compress it by, for instance, sitting on, when people used to carry big old wallets, right? I don't even carry a wallet anymore. My credit cards are in there. So if I lose my phone, I'm screwed.
I need to cancel my phone.
No, I just told her. That's where it goes.
I got one.
Huh?
I got one too.
You have one of those? Yeah. Right? But I just know where it is all the damn time because I'm either looking for money or my phone, right? But when, it was especially dudes because they're more likely to carry their wallet in their back pocket. And they had all kinds of stuff, credit cards, and when we used to carry cash, big old chunks of cash in there. Ones, really. And then when they were sitting, right? I saw that. You're making it right? So when they sit and they actually compress their sciatic nerve, not bilaterally, if you don't compress them the same way, you can actually compress your sciatic nerve and cause sciatica, and you're going to get deadening and loss of sensory function all the way down your leg because of where the sciatic nerve actually innervates. So let's look at where the sciatic nerve does. What?
He just moved his wall.
Yeah, you gotta switch it between the sides, right? Go ahead.
So it's because I had a friend that had piriformis, and the sciatic nerve goes like under it or through it.
It does. The piriformis is right here. So you can see the sciatic nerve right there, right? Okay, so here's your sciatic nerve. Let's watch where it goes. So the sciatic nerve is going to innervate anything in the thigh that you didn't already get, right? But then please note that it goes way the hell further than that. It's going to go down, and right in the popliteal region, it's going to branch into the tibial nerve and the common fibular. Now, just logic, guys. You're looking for the tibial nerve and the common fibular. Which one's which side? Tibial nerve is medial. Common fibular is lateral. Yes. And then the common fibular will branch into the deep and superficial. Which one goes deep, which one goes superficial, and call them that. Right? It ain't that hard, right? You think it's hard to be a doctor. No, they even only have to make C's in med school. It's not that hard, right? Have you met a doctor that you're smart of?
They only have to make a C in med school?
Yeah.
That's scary as hell.
Yeah. What do you call somebody who makes C's in med school? Doctor. That's what you call them. What?
That's why we don't ask.
And you're worried about the nurses that make C's.
I'm worried about everybody that makes C's. I am the most skeptical patient you could possibly have because I go in thinking I'm smarter than them. And sometimes I'm so wrong and it's delightful to me. I'm like, oh my God, that's so fun. My husband had surgery, that clavicle surgery, you know, yes, I showed you guys. So we went in and one of my friends, who was a former student who is now a nurse, and her father is a surgeon. I was like, who do I go to for this surgery? And she found him for me. And he was a badass, just total badass, knew everything. And then the anesthesiologist comes in to talk to us, like right before he's doing the anesthesia. And this guy knows everything. He knows history, he knows types of anesthetic, he knows different kinds of interaction, he knows all of the physiology, and I'm like, oh God, this is great. I was so excited. I love physiology, and he was so into it. And we were like talking about history of using these and why you don't use opioids in these situations. So I do love it when people are well educated. There aren't that many of them though. Okay. I am totally serious. Okay, here's your common fibular, and then the common fibular will branch into the deep in the superficial fibular. And then the one that I added this semester, and everybody was like, why the hell did you add that one? Is this little guy right here. Because I added that one because that one is the pudendal nerve that innervates your junk, and you literally would not be here without it. Because ain't nobody would have made a baby if it didn't feel good, right? So that's the pudendal nerve right there. It's your favorite nerve, or it's gonna be. That's it, right? Maybe not yet. You don't feel good about it, but later it's gonna be your favorite nerve. So that's the pudendal nerve, and they dissected it out on both campuses so that you can find it. The pudendal nerve innervates both sensory and motor function to the penis and the clitoris, which are the same structure, by the way. Everybody has a penis, right? Some of ours just pee, and the other ones are just for pleasure, right? The clitoris just doesn't pee. I don't know, it's better design, if you ask me. So, innervates that. Also innervates your perineal muscles, the muscles that are holding everything in there, and your sphincters, right? And then also the sensory function of all of that stuff, right? So pudendum means shameful in Latin because it does.
They found it in women.
They found it in women first. They named the entire female genitalia the pudendum, which means the shameful space, right? And then they named the nerve the pudendal nerve. And then later on, when they found it in men, I know that they wanted to change the name to the most awesomest nerve of all nerves, and they did not. However, so that's the pudendal nerve. Yes, and yes, you need to know it, right? And so if somebody stimulates your pudendal nerve without your consent, you're going to sock them. I've been trying, it's funny because like the whole consent conversation is really happening early and often with children, and I've got an 11-year-old boy, right? And not only have I had to have the consent conversation with him, I mean, he's nowhere near sexuality. He's like, gross, stop talking about that. However, consent is really important because the girls who mature so much faster have big crushes on him, and they're constantly like manhandling him, right? Like just like pulling on him and yanking on him and dragging him across the floor. And I'm like, we're gonna have a consent conversation, all of us together, right? No means no. I was like, you tell him no means no, right? No means no, no matter who says it, right? Consent is a high five and a hell yes is what it is. Okay. And he's saying no. So I had to have that conversation with little girls. I was like, I want you to know that consent is important. Okay, so. Yeah, I'm the weird mom. Okay. But it's right, it's important. We can't tell dudes that consent is important if it's not important with women. You keep your hands to your damn self unless he wants you to touch it, right? Everybody. Okay. So now we're going to do autonomic nervous system. We're going to start on autonomic nervous system. So when I say autonomic nervous system, first question, go ahead.
Oh, I just had a question about a Ramus and the spinal nerves. Is that
Yeah.
a Ramus only from spinal nerves?
Yes.
Like, is that like,
Yeah. No, well, the Ramus is a branch of the spinal nerve.
Right.
Yes?
Yes.
Yes. And the Ramuses that branch to form the plexuses are all the anterior or ventral ramus.
Okay.
Yes.
And then like I was just confused because you have like the sciatic nerve is called nerves and not a Ramus.
No, it's because after they actually go forward, so let me just show you this. I don't ever test you on this, but it is a lot more complicated than I showed you. So in this figure right here, hold on. In this figure right here, do you see that we're doing anterior rami, or in orange, right? But then there's some cords and stuff that go in there, especially with this one. Hold on. Here we go. They're all anterior rami, right? And then there's a bunch of stuff that happens in the middle, and they're called cords and divisions and all of that kind of stuff. But what we hold you responsible for is the nerves, right? Okay. So the nerves that we learn are all branches from the anterior rami. Good?
Yeah.
Okay. All right. So let me introduce you to the autonomic nervous system more deeply than you learned it before. What the hell is that? Okay. So, balls. I didn't say that.
I'm not recording balls.
If I were Scottish, that would be charming. Although they would say bollocks, wouldn't they? Right? They would. Bollocks. Yeah, bollocks means testicles. It totally does.
They mean testicles.
That's what it means. So I need to introduce you guys. 18? Okay. You didn't know that?
I'm sure he knows.
Okay, so let me introduce you to the autonomic nervous system. And so I want to just introduce you to the basics of it. First, people have trouble with terminology with nervous system. So here's the question. If I say autonomic nervous system, do you know whether I'm talking about CNS or PNS? What is it? PNS. Do you know whether I'm talking about somatic, afferent, or motor efferent? Oh, sorry, not somatic, afferent. Sensory afferent or motor efferent. Which one am I talking about? Motor. And what are the effectors for the autonomic nervous system? Cardiac muscle, smooth muscle, and glands. Yes? Got it? Okay. So that's what people have trouble with. So specifically, you know that I'm like thinking about motor information maybe to the heart, right? Okay. So why do I take the time to talk about this? Because if you control cardiac muscle, smooth muscle, and gland function, you end up controlling most of the body systems that land you in the hospital. Cardiovascular is controlled by the autonomic nervous system by controlling, of course, cardiac muscle. But also, what do you control in vessels? Constriction. Yeah, that's smooth muscle, vasoconstriction, vasodilation. Respiratory function, the diaphragm is not innervated by the autonomic nervous system, but the diameter of the bronchi and the bronchioles is, right? That's smooth muscle. Digestive function is all wiggling and squirting with smooth muscle and glands, right? And urinary function is really all smooth muscle and glandular function. And reproductive function is all smooth muscle and gland. Everything from erections to ejaculations to hormone secretion is all autonomic. So the reason I take a minute to tell you about this is because if you're going into human health, you need to know how these things are supposed to be wired up, right? Now, it is all involuntary, it's all automatic, it's not hooked up to your cerebral cortex. It's hooked up to older portions of your brain, like your medulla oblongata, your pons, your hypothalamus, okay? So let's just do the beginning anatomy, and then I'll let you guys go. So here's what I want to do. I want to talk about how, right now, you don't have a quiz, right? There's not a tiger in the room. So which branch of the autonomic nervous system should be in control right now? Parasympathetic. Then a tiger walks in, and a sympathetic. So here's what I want to do. I want to get an anatomical stimulation to my heart right now and my uterus right now, right? And then I want to have a tiger walk into the room and talk about the anatomical pathway about how I get the stimulation to my heart and my uterus in that situation. Does that make sense? Okay, so we're going to do that quickly. Okay, so right now, the parasympathetic nervous system is in control. This is the parasympathetic nervous system. It looks super complicated, but it's really not. Because with the parasympathetic nervous system, all innervation starts from either 4 cranial nerves and 3 sacral spinal nerves, right? That's all it starts from. Whereas with the sympathetic nervous system, it all starts from the thoracic and lumbar region of the spinal cord. So with that in mind, can you not immediately tell the difference in this picture in your notes? Without labeling, which one is this? That's sympathetic, that's parasympathetic. Okay, so with our last couple of minutes, let's just practice. Okay, so now I want to say everything's chilled, my brain has looked around and it's assessed the situation. I'm not super stressed out, no tiger, right? And so what I want to know is how anatomically do I get the signal to my heart to chill out and the signal to my uterus that we can afford to do uterine contraction right now. Does that make sense? Okay. So what I'm going to do is right now, my cerebral cortex says no tiger, and it tells which portion of my brain controls heart rate. Medulla oblongata, which is right down here. And then the medulla oblongata is going to send a signal out a nerve that you know to your heart. Vagus, cranial nerve number 10. So it's going to go out cranial nerve number 10 to calm down the heart. Yeah? Okay. Now, I am also going to say, okay, if you're ever going to contract your uterus, this is a fine time because you're not doing anything else, right? And so how do I do that? Another portion of my brain, which is close to the brainstem, sends a signal down all the way to the sacral region of my spinal cord via what kind of tract do you think? What kind of tract? Just guess. Yeah, it's projection tract, yeah? Send it out a projection tract, and then I'm going to go out to the uterus and say, we can contract now. Yeah? Okay, now, Tiger walks into the room. I need different things from my heart and my uterus, right? So now, last thing, and then I will let you guys go. How do I tell my heart it is time to speed up and my uterus it is time to slow down? How does that anatomical route happen? Okay, with the heart, again, cerebral cortex says, oh crap, tiger. Tells the medulla oblongata, stop wiggling, I'm going to take this last second. Okay, tells the medulla oblongata, and then it sends the signal down to the thoracic region of my spinal cord, follow it out, goes out to the heart and says, oh crap, tiger, get moving, right? And then it also continues to go all the way down to here and sends the signal out to my uterus that says, we can't afford uterine contraction right now. So it's two different anatomical routes, right, for two different functions. So when people normally see these pictures at first, they're like, I cannot do that. You can, because that's parasympathetic and that's sympathetic. For people who don't care about anatomy or physiology, they actually call the sympathetic nervous system the thoracolumbar division, because that's where it comes from. They call this one the cranial sacral division, right? That makes sense? Okay, we'll pick up there on Monday.